Good afternoon. So I have the opportunity to meet Melissa Ricker today. She is, she's a family medicine, so MD for family medicine, and she's working at the Verona Clinic, which is really, really exciting. Most of you know who I am. I'm Elisa Wiest. I'm the program manager at the Verona Senior Center. And we feel very strongly about women's health. So we wanted to bring some of the experts to the table. So without further ado, I'm going to hand this over to Melissa and let her take it from here. But I just wanted to give her a warm welcome and say thank you for joining us and doing this presentation for our seniors today.
Of course, thanks for having me. I really appreciate it. And looking forward to the chance to hopefully meeting you all in person someday soon now that COVID's starting to get much better. So today I'll be talking about a couple different women's health topics. And again, as she mentioned, I'm a family medicine doctor at Verona Clinic. All right, so first, just kind of disclaimers. I don't have any financial conflicts of interest, and it's always a good idea to talk to your specific doctor if you have any questions about your health or treatment recommendations, because everyone's a little bit different. And all of the information for this presentation was taken from Up to Date, which is a resource that all of us doctors use that takes all the most recent research and compiles it in one spot. So that's where all this stuff is from. So the first thing to talk about is what is osteoporosis. So osteoporosis is a diagnosis of low bone mass, fragile bones, and a disruption in the bone architecture. And this is important because those things lead to poor bone strength and give women an increased risk of fractures. The most common places to have a broken bone are in the spine, in the hip, and in the wrist. And so we really care about screening all women to help identify people who have this low bone mass, so we can identify those that are at high risk of fractures, and then we've got treatments to help improve bone health to prevent these fractures. So, and then you can see in this picture, like I guess I would have a point, there. I'm not sure if you can see my pointer or not, but people commonly have fractures of the lower spine, or where like the thigh bone or the femur meets the hip. And then you can't see the wrist bones on here, but that's the other common one. So the symptoms of fractures, of osteoporosis, people don't typically have any symptoms at all until you, of course, have a fracture. And as with any broken bones, that can lead to a lot of pain. It can decrease your ability to walk and do your normal things that you do on a daily basis, especially if you end up having a fracture of the hip. People can be laid up for quite some time with that, or wrist fractures can impair your ability to write, drive, pretty much do anything. And then commonly fractures of the spine can cause people to have a loss of height. So the most prevalent type of fracture from osteoporosis is called a compression fracture. And that's a fracture of the lower spine, as you can see in this picture up here, where the different vertebrae get compressed. And so a lot of times people end up getting imaging for a different reason, and then they end up finding these compression fractures, and people aren't having any symptoms from them. But then in other people, these compression fractures can be extremely painful if a nerve gets compressed. And again, these compression fractures can lead to loss of height too. So the different causes of osteoporosis, the most common ones are low estrogen and also increasing age. Those tend to kind of go hand in hand. But there's a number of other things that can cause osteoporosis too. Those can include calcium or vitamin D deficiency, especially here in Wisconsin. A lot of people are at high risk for vitamin D deficiency. If you have kidney or liver disease, hyperthyroidism, hyperparathyroidism, which is a hormonal imbalance that can affect your calcium and vitamin D levels, Cushing syndrome, which has to do with the cortisol and steroids that your body has, celiac disease, or other causes that make you not be able to absorb vitamin D as well. So a lot of things of like the intestines and the stomach, those kind of diseases. And then there's a lot of medications that can also put you at higher risk of osteoporosis. So a lot of steroids like prednisone and immunosuppressants, which are medications that can be used for autoimmune diseases, cancers, things like that. And there are certainly a lot of other causes of osteoporosis too. So we talked about screening, and so who should be screened for osteoporosis? So we recommend that all women over the age of 65. And then we also recommend that women who are less than 65 years old but have already completed menopause and who also have additional risk factors for a bone fracture. So those include having a previous fracture, those on steroids, those are the low body weight. If your mom had a history of a hip fracture, that can put you at higher risk. If you smoke, if you drink a lot of alcohol, if you have rheumatoid arthritis or other autoimmune diseases, or if you went through menopause at an earlier age than typical, again, if you have liver disease or if you have anything that impacts your ability to absorb vitamin D through your diet. So the way to diagnose osteoporosis, there's actually 3 different ways. So there's the fracture risk assessment tool, also known as the FRAX tool, it's hard to say, which looks at all the different risk factors that we talked about on the previous slide, and then calculates your risk of having a fracture. And that's your risk of having a fracture if you weren't to undergo treatment for osteoporosis. And so kind of the cutoff is if that FRAX score shows that you have a greater than 3% 10-year probability of a hip fracture, or if your probability of getting any other fracture over the next 10 years is greater than 20%. That'll give you the diagnosis of osteoporosis. Also, if you have what we call a fragility fracture, which is a broken bone that occurs just spontaneously without any trauma, or if you fall from just standing height and you break a bone, that gives you the diagnosis of osteoporosis. And the last way that most people are probably most familiar with is through a bone mineral density scan, also known as a DEXA scan. So DEXA scans, sorry, I'm just gonna keep moving this picture. So DEXA stands for Dual Energy X-ray Azimuthtometry Measurement. That's a mouthful. And what that is kind of like an X-ray that measures the density of your bones and then compares it to healthy young adults without any medical conditions. It takes a measurement of the bone density at both the hip and the spine. And if the scores of the hip and the spine are different, then they take the worst score. So math is not my strong point, but essentially if your bone density is kind of similar to less than 2.5 standard deviations from a healthy young adult's bones, then you get the diagnosis of osteoporosis. And if you're not quite so bad, so like 1 to 2.5 standard deviations essentially from a young person's bones, then you have osteopenia, which is kind of, so you've got healthy bones and then it can progress to osteopenia, and then it can progress to osteoporosis. And this is what the DEXA scan looks like, so I've been told. So when should you repeat a DEXA scan? So again, we say at age 65. And then so they kind of stratify the osteopenia, which again is that kind of middle ground between healthy bones and full-on osteoporosis. So if you are on the worst end of that middle ground, and then you have risk factors that might make you continue to have bone loss, for example, like smoking, steroids, other medications that can affect your bone health, then we recommend that you get a repeat DEXA scan every 2 years, just to make sure that we're keeping an eye on how your bones are doing. If your bones are on the lesser side of the osteopenia scale and you don't have any risk factors that would put you at risk for having ongoing bone loss, then you can repeat your DEXA scan every 3 to 5 years. And if your DEXA scan shows that you have pretty much normal bone health, then you can go 10 to 15 years without one. And again, this is all important to have a conversation with your doctor about. So most importantly is how to prevent osteoporosis. So everyone needs calcium in their diet. That's less of a problem here in Wisconsin, luckily, but you want to get 1,200 milligrams daily. And that includes both calcium that you get in your diet through your dairy products and green leafy vegetables, almonds, stuff like that, and supplements. So whatever you don't get in your diet, you should make up for in a supplement form. Vitamin D, again, people in Wisconsin are at a little higher risk of. And so we recommend 800 international units daily. So you can get that over the counter anywhere. Then we also recommend exercise, and specifically what we call weight-bearing exercise. So things that are putting pressure on your bones. So resistance training, like lifting weights, jogging, jumping, walking. Those are all good things that put a little stress on your bones and therefore make them stronger. And so we recommend greater than 30 minutes 3 times a week. Other really important things are to quit smoking if you currently are, and also to limit your alcohol intake. So if you do end up with the diagnosis of osteoporosis, your doctor may want to get some additional labs. Those would include a calcium level, a vitamin D level, other electrolytes, kidney function, because your kidneys are in charge of the balance of calcium and vitamin D in your body, as well as your liver. And then also checking for anemia, signs of infection, things like that with the blood counts. So, and then if you have the diagnosis of osteoporosis, then we want to treat it. So, and again, the point of treatment is to prevent you from getting broken bones. So the first thing is that we want to make sure that before we try any other treatment, that your calcium and vitamin D levels are good. And so again, they'll do those labs to check those levels, and then you should continue your calcium and vitamin D supplements. Then the first line therapy for osteoporosis are bisphosphonates, and those are called alendronate, or you might know it as Fosamax, and risedronate, which is also known the brand name of Actonel or Atelvia. And these medications help to build up bone mass and again, decrease your risk of having broken bones. So these bisphosphonate medications are oral ones, and you take them once weekly. And it's important to wait at least 1 hour after you take the bisphosphonate to take your calcium supplement, because the calcium supplements can kind of interfere with your body's ability to use the bisphosphonate medications. And say you have a broken hip, you were just standing and fell and unfortunately broke it, that would qualify as that fragility fracture, giving you the diagnosis of osteoporosis. And then you can start this bisphosphonate medication 2 weeks after. The risks of bisphosphonates, they can affect the esophagus. And so sometimes people will get acid reflux, esophagitis, which is inflammation of the esophagus. And sometimes people can get ulcers. But there's things that we do to prevent that, which I'll get to in a minute. Very rare complications that you may have heard of would be osteonecrosis of the jaw, meaning like the bone breaks down. Again, very rare, and we watch for that. And then the other rare complication would be a break of the femur bone, which is the thigh bone that you can see in red here on this picture. But again, those are rare. Reasons that people should not take bisphosphonates are if you already have a disorder of your esophagus, or if you can't stay upright for 30 to 60 minutes after taking this medication. And so we always want people to stay upright for 30 to 60 minutes after taking it to help the medication to pass through the esophagus and prevent those potential complications of the acid reflux and esophageal inflammation, ulcers, things like that. Other reasons why you should not take a bisphosphonate if you have chronic kidney disease, because then the kidneys again affect your calcium and vitamin D levels and how this medication is metabolized or excreted from the body. And then also if you have a specific type of gastric bypass surgery called the Roux-en-Y, because then that impacts your body's ability to use this medication appropriately. And yeah, so those are kind of the big reasons why someone should not take a bisphosphonate. So say you do have one of those conditions that prevents you from using a bisphosphonate, then there are other options. So there is an IV form of those medications called zoledronic acid. You might have heard it called Reclass, Zometa, and by giving it IV, it bypasses the esophagus, so you don't have to worry about those risks. So you can do the IV form for people with disorders of their esophagus. Again, if the bisphosphonates cause you to have like an upset stomach or acid reflux, if you have that gastric bypass surgery, or if for whatever reason you're not able to sit upright for that 30 to 60 minutes. If you fall into the category of people with chronic kidney disease, then your option would be a medication called denosumab or Prolia. The only thing with this medication is that if you stop taking it, it can make your bone health worse. So that might be a medication that you'd have to take for the rest of your life. And then the last category of medications that are used to treat osteoporosis are called teriparatide or Forteo. And I'm not going to attempt to pronounce that, but Timlos. And those are for people with very severe osteoporosis. So people with that T-score on the DEXA of less than 3, if you have a severe T-score on the DEXA scan plus one of those fractures from standing height, or if you have a lot of those compression fractures in your lower back. That's when we would try to do much more intense therapy. And then when you're on the medications for osteoporosis, we want to measure how beneficial it is for you. And so people will then get a DEXA scan 1 to 2 years after starting the medications, and then every 2 years after. And this is an example of what those DEXA scans might look like. You can see on the left, this is the spine. And then you can see on the right, that's the hip. So it's just seeing how dense the bone is there. And then when to stop therapy. So for the alendronate or the Fosamax, typically people will take it for about 5 years, and then they'll do DEXA scans and make sure that the bone density is stable. And then if they haven't had any compression fractures, then it should be okay to stop that medication. However, it is possible to continue these medications for up to 10 years. And those are for people, again, with pretty severe osteoporosis. And then say that you stop taking the medication and then you get another DEXA scan and it shows that you've had greater than a 5% bone loss, and that's over 2 years, then you can consider restarting the Fosamax or any of the other medications. So then the next topic for women's health is breast cancer screening. So there are a couple different ways to screen for breast cancer. There's the screen film mammography, which is the most basic one that probably you all think of. And then there's also some newer types of mammograms called digital mammograms or some 3D mammograms that are used for women with really dense breast tissue to get a better evaluation. And your doctor will decide which type of mammogram you should have, or the mammogram techs will also be able to figure that out. Some people ask me about whether they should get an ultrasound or an MRI breast cancer screening. And that is only for women who are at a very high risk of breast cancer, for example, through like a family history of a BRCA mutation, or if you have a mammogram that shows something, then they'll go on to the next step to do some further evaluation with the ultrasound and MRI. But for the most part, for women who are just getting their typical breast cancer screening, you don't need the ultrasound or MRI. And in fact, the regular mammogram is better. Another thing that has kind of changed in recent years is having doctors do breast exams and having patients do their own breast exams. And we're kind of finding that those aren't always the most reliable tests. So it's still good to pay attention to your own breasts and see if there are any new lumps that pop up or skin changes or discharge. You should definitely let your doctor know about that. And then we would get a mammogram earlier. So when to get mammograms? So for women of average risk, which I'll get to the other categories in a minute, but for most women, you should get a mammogram every 1 to 2 years. And that's a good conversation to have with your doctor about whether you should do it every 1 year versus every 2 years. I think most people are starting to be on the every 2 year plan. If you are at moderate risk of breast cancer, for example, if you have a mother or a daughter or a sister with breast cancer, but no known BRCA mutation, then you could still have a mammogram every 1 to 2 years. If you are high risk for breast cancer, for example, if you've had extensive chest radiation between the ages of 10 and 30, if you yourself have that BRCA mutation, or if you have a first degree relative, so again, mother, sister, daughter with the BRCA mutation, then you should get an MRI every year. And then people ask about how long do I have to get mammograms for? And so typically we recommend 50 to 74, but then when you get to 75 years, it should be a conversation with your doctor about whether you would like to continue getting mammograms or not. Some people are fortunate and are in really, really good health at age 75, and so they have the potential to live for 15, 20 more years. And so then it would probably be a good idea to keep getting breast cancer screens. You also need to take into account if they found something, would you be willing to undergo the removal of the lymph or of the spots, chemo, radiation, stuff like that. And if you don't think you'd want to go through that, then there probably isn't a point of getting mammograms anymore. So yeah, it's a good conversation to have with your family and with your doctor. Another thing to consider is that as people get older, they're more likely to have something called ductal carcinoma in situ, which is where there are some abnormal cells in the breast tissue, but they may or may not move out of the breast. And so that means like they may or may not be significant to your health. And so if you get mammograms after age 75, the mammogram is more likely to show something that's concerning for cancer, but then it might be diagnosed as this ductal carcinoma in situ that you may or may not have to do anything about. So it's up to you. I'm sure your doctor will support you either way. And then genetic testing is another question when it comes to breast cancer screening. Oh, sorry. There we go. So the United States Preventative Services Task Force, which is a group of doctors that come up with all of our screening guidelines, say that genetic testing and counseling should be offered to all women with a personal or family history of breast, ovarian, tubal, which is like the tube that connects the ovaries to the uterus, or peritoneal cancer. And peritoneal cancer is cancer of the lining that essentially kind of holds your organs in place in your abdomen. So it's a pretty rare cancer. So those women should be offered testing, and also people who have a family history of that BRCA mutation that they're aware of. So you have to meet one of those criteria and then have an increased risk of cancer on one of the risk assessment tools that your doctor can tell you more about. And my last topic for today is menopause. So a lot of women are not aware that hot flashes, unfortunately, can continue until the age of after 70. People age 60 to 70, 12 to 15% still have hot flashes. And women over the age of 70, approximately 9% still have hot flashes. Unlike in younger women, we often do not recommend hormone therapy to treat these hot flashes for women over the age of 60, because at that point, the risks of hormone therapy often outweigh the benefits. And those risks include heart disease, stroke, and blood clots. So some pretty severe things. Things that have evidence to back them up and are commonly just as effective, if not more effective than hormone therapy, are antidepressant medications and also weight loss. And then we also tell people things that you probably are already aware of, like dressing in layers, making sure you've got plenty of fans at night, avoiding spicy foods or hot foods, things like that. So, and that brings me to the end of my presentation. So thanks so much for listening, and we hope to see you around the Verona Senior Center sometime soon or around Verona Clinic. And I'm not sure when you'll be seeing this, but I'm currently recording it on Thursday, May 6th, and Mother's Day is this weekend. So I hope you all have a very nice Mother's Day too. So thank you. Take care.